Hello, thanks, Kayla. So, I'm clearly highly qualified to speak about outpatient medicine. No, I'm delighted to be here. I actually learned and refreshed my memory on a lot of this stuff doing this. Clearly, as an intensivist, we love labs. So, the pleasure was learning how to scale that back and remind myself when you don't need labs. So, if you have your phone, please take it out. Because it's 2:20 in the afternoon, you've been here all day, you ate lunch at some point, and this is my time to just curl up and take a nap, and I know that some of you are feeling the same way. So we're going to make this interactive. I have no disclosures. We are going to talk about 4 common outpatient scenarios, which labs would be indicated and why, how to interpret them, and if nothing else, you can learn a little about what we call groups of animals. So we'll start out easy. This is a crow. What is a group of crows? Yes, that's true, but hang on. That's why I started easy. A murder, a scourge, a scurry, or a storytelling. So if you have your phone, if you text that number, and then the text content is the Kathryn Miller 777. You should be able to vote using a letter. So if you want to, so that what you're going to text it to 22333. The text content is the Kathryn Miller, and then it should tell you that you're in. Yay. And then, so I'm cheap and I didn't want to pay for this, so there's only 25 people that can vote, so hurry up. It's exciting. What I like about this is you can fall into sort of group think. So if one's winning, you're like, yeah, A looks good. All right, I'm mostly gonna. Does anybody not know how to make this work, or their phone's not participating? Because we're gonna do this for real with what labs you would order. This is just for fun. Okay, congratulations, A. Did it say the poll's closed? Yeah. Great. Not that you didn't get to participate, but good that we figured out how that works. So it is a murder of crows. Don't ask me why. All right, so let's talk about Henry in scenario A. Henry's 45 days old, completely unremarkable past medical history for a 45-day-old. Nothing exciting about his birth history. He's febrile to 38.9. But otherwise, he's completely the same. You can read it if you don't believe me. Completely normal. Here's his vital signs. I tried to make them unexciting, aside from his fever. If anyone disagrees with me, holler. You also have to participate, otherwise I'm just going to talk at you for an hour, and that's awful. And there's nothing on his physical exam. So what do you do for him? Now this, if no one's voted yet, this time since there can only be 25 at a time and I want as many people to vote as possible, just the right side vote for now until it says the poll is closed. And then we'll still be right side versus left side. Left side versus right side. 45 days. Is 2 things or not? And you note I didn't tell you what time of year it was, but we'll pretend it's now. This is fun to watch. It's like a race. Oh, nothing. Okay, that's fair. Raise your hand if you don't want to do anything. We'll call that supportive care. All right, one vote for supportive care. All right. Okay, poll closed yet? Did this side vote too? No? Okay. So, all right. So the right side of the room votes for, and Kayla, your job is to help me remember this. So the CDC blood culture, UA, and urine culture, with one vote for supportive care. Okay, this side. Go for it. Don't worry, we'll alternate back and forth because it won't always be fair for this part to lead the. So it looks like this side agrees. But kind of number two is what I would call the kitchen sink, which is one of everything. So, what if Henry's 3.5-month-old instead? Otherwise, the story is identical. I'm not joking. Literally, all I changed on the slide was his age. Take my word for it. This time, we'll just do everybody. First 25 wins. Now he's 3.5 months old. A whole lot of not LPs all of a sudden. Oh, one person. Still voting for supportive care? No. Okay. Anybody for supportive care, raise your hand. All right. So this time the winner is just the CDC. Second place is with the urine and a blood culture. All right. So why do we care? So in this particular age group, what scares us are the things that we cannot see. So serious bacterial infections. So bacteremia, meningitis, UTIs, these are things that hide, that you may not have any idea are going on. Sometimes you can, sometimes not. Then there are things that we can see that are also a little less common. So bacterial diarrhea is not that common now. Pneumonia is a little more obvious sometimes, and then bone and joint infections. The epidemiology behind this has changed. Once upon a time, the winners were strep, pneumo, and H. flu, but then we went and got vaccines, and the numbers of these diseases fell tremendously. Over 99% for invasive Haemophilus, and 77% for pneumococcal, and that's before we expanded the number of serotypes that the pneumococcal vaccine covered. And this is true with a decrease in incidence of these even among those children who are unimmunized, and the best guess is that's what herd immunity is for. Now, we're not going to talk about how that's disappearing in some places. So consequently, in the face of these new vaccines, now under 3-month-olds win most often with a UTI, namely E. coli and Klebsiella being the most common. When you hit the 3 months to 3-year age, pneumonia begins to win, and UTI now comes in second. And then the other interesting thing is under the age of 12 months, the incidence of children with UTIs who require hospitalization has increased, and more present with pyelonephritis and sepsis. And coincidentally or not, this happens to go along with increased amoxicillin and penicillin resistance. So choosing antibiotics is, as we all know, critical. What do you call a group of alligators? An army, a herd, a congregation, or a cloud? Or scary? Whoa! Yeah, I agree. A cloud of alligators would be ridiculous. You're right. It's a congregation. What they're congregating about, I do not want to know. So who gets a CDC? So for sure, we know that CDCs are associated with serious bacterial infections, particularly those children who have white counts less than 5 and greater than 15. If you like statistics, you're looking at that positive predictive value and saying, are you joking, 26 to 80%? How is that useful? Yeah, it's not. It's a pretty variable range, but there is value. So there's a couple of pretty large studies looking at what CBCs actually did for informing the care of these patients. And in one of about 500 infants, there was an over 2 times likelihood of having a serious bacterial infection in those kids who had a white count above 15. A different one with even more kids found that by including the CBC, physicians were less likely to miss a serious bacterial infection. We always seem to order a CBC with a diff, and I think we generally always look at one of 2 numbers. So let's talk about the differential real quick. So neutrophils we know and love. They're increased with bacterial infections, certain inflammatory things, tissue damage, bone marrow malignancies, and decreased with things like viral infections, or particularly in neonates just being overwhelmingly infected. Their bone marrow runs out of the ability to produce neutrophils. Chemotherapy, obviously, antibiotics, and drugs that I'm hoping we're not giving infants, and then hereditary things will decrease it. Related to neutrophils are bands, which are the immature form that get kicked out in times of need. So if there's an increased band count, it's highly suggestive of a bacterial infection. We like the term left shift, which indicates that there are more immatures or more bands as an indicator of possible bacterial infection. I'd never heard this term, but apparently some will refer to a right shift, in which there are more monos and lymphocytes than there are neutrophils. Not actually a thing, but we do tend to point out when there are more lymphocytes, and then we tend to suggest that perhaps it's more likely to be viral. There's about 3 different ways that you can calculate an immature to a total count when you're looking at whether there's the likelihood of a serious bacterial infection. This is the one that I remember. You have it in your notes for your own reference, but take the immature neutrophils or the bands and then divide it by the total number of bands and total neutrophils or SEGs. And if it's above 0.2 or 20%, there's your objective left shift, and there's your increased suspicion for a serious bacterial infection. Lymphocytes are usually the second most common, and this is your cell-mediated immunity, or your B and your T cells. More likely to be increased in viral infections, but also bacterial and certain allergic things. And decreased, you're going to see these 4 things repeatedly. So corticosteroids or adrenocortical hyperfunction, stress, and shock will wipe them out. Monos, we talk about even less. So also indicative of potential viral infection. And then increased and increasingly less likely things that you're going to be encountering in this particular age group. Hopefully you're not seeing ulcerative colitis in a 3.5-month-old. I did my fellowship in Arkansas. I saw a lot of Rocky Mountain spotted fever. Certain leukemias, and then bone marrow failure will knock it out. Eosinophils are likely for allergic things like asthma, hay fever. Basophils, again, allergic things, and you see the percentages here. These are unlikely to be high, but can be with inflammatory things. And then there's your same 4 reasons that they can be low as what you see in lymphocytes. I'm going fast because I know you have these notes, and I think it's more interesting to talk about some of the other stuff. So would you agree that Henry gets a CBC? Anybody want to fight back? All right, I agree. Yeah, I have a very distinct memory of us with a patient, and you said, look, I really want a CBC, and you were spot on. Yeah, yeah, you were. It is true. That is exactly what happened. So who wants to interpret Henry's CBC with differential for me, or his white count? Pay no attention to his hemoglobin and platelets. Don't be shy. Okay. Low lymphocytes and a little bit of a left shift with 5 bands. How concerned are you based on this that Henry, and we'll pretend this is the Henry who's 3.5 months old, that he might be hiding a serious bacterial infection? On a scale of 1 to 10, where 1 is, why are you taking up my time in my office, and 10 is, wow, I'm calling 911. Total white count is not that high. No, he doesn't. He's completely fine. He shouldn't have bands, that is true. So anybody want to do the math on what his I to T ratio is? 70, so 5 divided by 76. So 0.07, so only 7%. So south of 20%. So it doesn't technically meet criteria for a left shift if you put all your eggs in the, it's got to be an I to T ratio greater than 20% or 0.2. A lot of kids will have some bands. To note that and to increase your level of suspicion a little bit is absolutely appropriate. But I deliberately made it kind of vague. So I made his white count smack dab in the middle, but then gave him a couple of bands, just to have something more interesting to talk about. So my level of concern would probably be somewhere in the middle, because he is a very well-appearing child. How about a bunch of elephants? Colony, brood, coalition, or memory?
Hey.
I do like a coalition of elephants. All right. It is actually a memory of elephants. Of course, there's other terms, like it's clearly also a herd of elephants, but a memory, which I like. All right, what about a blood culture? So generally less than 3 months, it is highly recommended. The evidence comes from a smattering of places. Here is just one example, looking at less than 3-month-olds who came to a tertiary care ED with fever without a source, which is what FWS is. And they found that of approximately 1,000 infants who showed up, 91.5% of them had a blood culture, which is a lot. 2.2% of them were positive, and of that, 8 also had a positive urine culture. So, and of those, not surprisingly, E. coli wins over strep because that's what we know now in this vaccinated age. Risk factors, again, if I had asked you, you probably could have guessed, being not well appearing and then having a UA that was consistent with looking like a UTI. You could argue, just based on pure numbers, whether 2.2% is enough to justify sending a blood culture on every single person under the age of 3 months. And I think we would probably all agree, although that number is small, that's a person. There's a baby affiliated with that. And you're already in there sticking the kid for your CDC, which we've all agreed he's going to get. So add the blood culture, because to miss 2.2% of children and send them home with a serious bacterial infection is painful. So are we going to send a blood culture? Yes, I agree. Urine. So it's also pretty much stone cold recommended that everyone under the age of 24 months who has fever without a source, regardless of sex, gets an evaluation for a UTI, with some exceptions. So if you are, looking at the sort of less than 12-month age, greater than 28 days, so beyond your neonatal age, up to 3 months, you absolutely have RSV, and you have nothing more significant than a fever of 38.5, you don't need to get urine. It needs to be the real deal. So you need to catheterize them for it or call urology to do a suprapubic tap. The only kids that are exempted from this is if they have voluntary urine control. That's rare if you're under 24 months of age. Then you can do a clean catch. The bag specimen is so tempting because you don't have to catheterize the kid, but it's so misleading. So 85% false positive. We talked about how there's an increased incidence in hospitalization for children with UTI under 12 months because of antibiotic resistance. Here's how you get it. You do a bag UA, you see positive results, you send the kid home on amoxicillin. 12% of the time you're actually going to miss it, so there's a false negative. So don't do it. And everyone gets the UA and the urine culture. So who gets a UTI in the first 3 months, boys or girls? Yell it. So I think tied is boys and both, and a little bit of girls. It is boys, actually, for the first 3 months, and it is more common in uncircumcised boys. After 3 months, girls win, and the incidence or the differential goes up with age. We're looking for leukocyte esterase and nitrate, and it's interesting that a positive leuk esterase is as predictive, almost, as a gram stain, actually looking for the organism you're going to treat. So more than trace leuk esterase has an 88% sensitivity, which means you're very unlikely to miss a UTI if it comes up positive. And more impressively, I think 98% of febrile infants with a negative leuk esterase did not have a UTI. So it's helpful, it's very, very helpful when it's negative. Nitrites, I tend to forget, only come if you have certain bugs. So they have to come from the Enterobacteriaceae family, which of course is the vast majority of things that cause UTI in this age group. But you can absolutely have a UTI with negative nitrates if it's not one of these things. And again, very, very sensitive. If both are present, the false negative rate or false positive rate is only 4%. So the likelihood that what you see is a UTI is extraordinarily high. The other thing you're looking for on the UA is the presence of bacteria. I generally think that one's sort of the least useful because you're still inserting a catheter through skin that is inherently colonized with bacteria. And we do a really great job cleaning everything, but there's still a chance at contamination. And then what's called pyuria, which is by definition more than 10 white blood cells per high power field. So you get the urine back, you have leuk esterase, maybe you have nitrite, then you're waiting for something to grow. Now it comes back with how many colonies actually means there is a real UTI if you get growth. The newest definition is if there's pyuria, so there's more than 10 white blood cells, and there's at least 50,000 single organisms that are known to cause UTIs in an appropriately collected specimen, that is a UTI. So when we get these back and there's 3 different bugs, there's 30,000 of one thing and 40,000 of another, that child is very unlikely to have a real UTI. After 7 to 14 days, you need to see these kids back. You need to make sure that they did indeed get better. This allows you to figure out if they have failed their therapy sooner rather than later, and if they get a recurrent infection to treat it. Everybody who gets a UTI gets an ultrasound of their kidneys. This has changed. This is not what I learned in medical school for sure. And it's to look for the anatomic abnormalities that set children up to get UTIs. What has changed everything, but where's the VCUG? That's what has changed. So ultrasounds are not necessarily cheap, but they're non-invasive and they're radiation-free. So the VCUG, or the voiding cystourethrogram, where you lay a child on a table, you insert something to put dye into their bladder and see if they have vesicouretal reflux, is highly invasive, highly uncomfortable. So do we really need it? And the answer is no for just a single UTI, unless there is something on the ultrasound that suggests there's something else going on. So if there's hydronephrosis or big kidneys, if there's scarring of any kind that suggests recurrent insult to the kidneys, or anything else that would suggest that there's some sort of obstructive uropathy or reflux, or other things like, surprise, you have a horseshoe kidney or you only have one kidney, those would be your unusual circumstances. You get a second febrile UTI, then you get the VCUG. So the recommendations are absolutely guided toward minimizing the number of children that get this very invasive, uncomfortable test and don't need it. So is he getting a UA and a urine culture? Yes. All right. So there it is. I got rid of the things that aren't as important. What did he have? He has a UTI. Way to go, Henry. All right, so this is the same term for 2 different kinds of birds. That's an American goldfinch and a ruby-throated hummingbird. Flamboyance, gaze, charm, or tribe. Really changed. All right. Right again. It is a charm, which makes sense. A charm of hummingbirds. It is a flamboyance of flamingos, by the way, which I think is delightful. Yes, of course it is. Yeah. So other things. So now we get exotic. Do you send a CRP? Do you send a procalcitonin? There's at least a handful of outside referring hospitals and clinics that will every once in a while call in and tell me procalcitonin, and I just smile and nod. So yes, they are absolutely associated with serious bacterial infections. A CRP higher than 2 on the high sensitivity CRP, which is what Rainbow uses, has better sensitivity and specificity than a white count above 15 or less than 5, and that's true of your procalcitonin as well. The problem is CRPs rise more slowly than a procalcitonin, so Johnny-on-the-spot parents that scoop their kid up after the first fever who's been sick for maybe 2 or 3 hours, their CRP hasn't had time to rise. So it's going to be low and going to potentially mislead you. Procalcitonins are great, but they're a lot of money. Takes time to run them. By the time some of them come back, you've long since had to decide what to do with the child, and we haven't yet figured out whether they are going to impact the actual care that we provide to admit them, to give antibiotics, et cetera. The lumbar puncture. I think everybody knows under 28 days that decision is easy. There is no decision, you get one, with the exception of RSV, which can also be debated. So 28 days to 3 months, it's less clear. A lot of literature out of the UK is trying desperately to come up with actual recommendations that say, please don't do it automatically, but there is no consensus just yet. But most people agree if they're well appearing and they're previously healthy kids, as long as they're above 28 days, they don't necessarily need an LP. Over 3 months, the recommendations are pretty clear. Don't do it unless there are neurologic signs. So if the kid in front of you is altered in some way, sleepy, lethargic, not eating, yes, maybe you add that to your workup. And yes, it's true that white counts less than 5,000 are more likely to be associated with meningitis than bacteremia. It's still somewhat limiting. If you were to only use less than 5,000 as your cutoff to do an LP, you'd miss 2.1 cases for each one that you detected. If you only did it if it was above 15,000, then you'd miss 2.7. So a knee-jerk response just based on the white count is going to lead you down the rabbit hole. What about respiratory viral testing? We've gotten really good at it. There's lots and lots of different types of tests we can run. We can test dozens of viruses. Rainbow is a little more limited than where I was a fellow, where we had all of these things. But we can still do it, and it comes back really quickly. So yes, if there's respiratory symptoms, do it. If they're RSV positive and febrile, so if you go back, if you remember like 4 slides ago where I told you if you were the right age, you were RSV positive, and you had less than a 38.5-degree fever, you didn't necessarily need urine culture. If you are more febrile and you're RSV positive, there is an association with E. coli UTIs. To the best of my knowledge, no one has figured that one out yet. If it's flu season, go ahead and test for it. If they're flu positive, stop. That's the only workup that you need. They're very unlikely to have a coexistent serious bacterial infection unless they've come to play with me in the ICU, at least like this kid that you're seeing in front of you. If it's not flu season, don't just look. The yield is likely to be quite low. And speaking of respiratory stuff, you don't need to get a chest x-ray unless they have respiratory symptoms. The children for whom this does not apply are those that are, are immunocompromised for some reason, whether they have cancer, they're asplenic, they have HIV. These kids basically get the kitchen sink. You can feel better about your workup if you find out they were vaccinated in the last 24 hours, or you can find a source. You see the otitis, you look at the urine, and it's clearly a UTI. Teething, which parents love to blame fever on, is extremely unlikely to give you a fever above 100.4, which is 38. So if that's what you're trying to blame, think a little harder, or if that's what the family's trying to blame it on. All right, so we all agreed on these. Would anybody want A CRP or a procalcitonin or an LP? Own it if you want it. It's okay. No? Cool. Please don't. I would say with him, he doesn't need viral testing, he doesn't need chest X-ray. Anybody disagree? Sweet. So other red flags that I just put on here kind of for your own reference, things that you know. If the parents are concerned, if your gut instinct is there's something wrong with this kid, they're behaving irregularly, if there's something on exam you don't like, whether it's their cardiovascular system and their perfusion, or it's something that you hear in their pulmonary exam, or they have a rash that you don't like, they look more dehydrated than you think they are, these bump them right up into the not well appearing category. These kids fall in the kitchen sink category. There are, apparently New England decided they all needed to have their own list of ways they protocolized who gets what workup for what situation. There's Rochester criteria, Philadelphia criteria, and Boston criteria. So I just gave these to you as a reference. But what you see is on H&P, they all focus on well-appearing children. They all agree you get a white count in UA. Philadelphia and Boston do tend to go right for the LP, and this is, again, well-appearing kids. High risk, of course, you get hospitalized and empiric antibiotics. That was easy. Low-risk patients, you get to go home, provided that you can follow up with someone. In Boston, they give you ceftriaxone, kick you out, but ask that you come back to get a second dose of ceftriaxone. And they have really nice negative predictive value. So this is just a guideline for if you have a well-appearing kid, what are various institutions' recommendations. Simpler still, I like this one. If you're over 3 months and you're non-toxic, you've had your pneumococcal vaccine and you're less than 39 degrees, you're an uncircumcised guy or a girl less than 2 months, then all you need is a UA and urine culture. And that's it. Kittens, not cats, just kittens. Braced family mischief or intrigue. I know which one always wins. I do this in a number of presentations. I don't know what abrasive kittens would be either. So it's actually an intrigue of kittens because they're intrigued by everything. They explore. Very good. All right, questions about fever and what to do with it. All right, so now Henry's peeing too much. He's 3.5, you know him well. Mom brings him in because he's peeing too much. Oops. Oh yeah, what do you do? Note that I've told you absolutely nothing else. I promise that my standing up here drinking water while asking you that question was not a hint. What do you know? He drinks a lot. 4 to 5 8-ounce glasses of juice, sometimes water, plus milk at meals. He has to drink water before he goes to bed, so sometimes he has accidents. None of this has changed. He's otherwise completely well. I promise these are normal vital signs. There's nothing on his physical exam. Here's his growth chart. What's wrong with Henry? He's drinking too much. He's a toddler. How would you make it diabetes? How would you change this story? Weight loss, good. Starving, so eating a ton. Okay. There was a voice over here. Oh. Okay. Good. Someone said waking up to pee. Good. There was something else. Okay. Yeah, so like a candidal diaper rash. Good. or if he's in underpants, has some sort of rash. All right, kind of similar. He's drinking the same thing, except now he had been dry for 6 months. Now he's having some accidents. And Grandma showed up and said, when did Henry get so thin? It's always a relative, because the child in front of the parent changes so subtly, they rarely see it until it's either super dramatic or all the other symptoms have caught up with them. Those are the same vital signs. Same physical exam, now there's his growth chart. Yeah. Now Henry has diabetes. So now what would you do? Didn't give you D and E together, which I could have. Pretty overwhelming, so you're gonna look for it. Good. So what's in a UA? Who looks at the pH? One hand. No, just kind of the number you skip and you start looking at other things. Makes sense. This is something I learned. So the normal healthy range is 5 to 8. Here in the Western world where we love protein, it's a little higher, so it's 6. It's a little on the lower end of the spectrum. It can be more alkaline in people with vegetarian diets or high dairy or milk intake. You care if you're looking at somebody who has a metabolic acidosis or who has kidney stones. And that's probably not you, that's probably the nephrologist that you have referred the child to. What is the specific gravity? What do you use it for? Hydration status, good. So its name's kind of what it is. So they just take the weight of the urine and divide it by the weight of water. So the normal is the exact same as water, or just slightly higher than that. And that makes sense, because if you're trying to tell the pre-syncable teenager that's in your office with a blood pressure of 85 over 40 how to drink enough, what do you tell her urine should look like? Water. Hence, you would have a specific gravity of 1. So if it's too low, it either means that you're drinking tons of water or there's some pathology there, which we're not even going to touch. If it's too high, it's concentrated, so this is your dehydrated kid, or there's more stuff in the urine, or again, there's other pathology. You should not have any protein in the urine. Here's what, for your own reference, what the pluses mean in terms of actual milligrams per deciliter from trace up to 4+, which is over 2 grams. How concentrated the urine is can affect the protein, meaning that if there's very highly concentrated urine, there may be reading that there's protein that isn't really there. And then very alkaline urine can also cause a false positive. We won't talk about this, but there's lots of reasons to accidentally catch intermittent proteinuria. Pregnancy would obviously be a surprise. And then continuous, now you're talking about real pathology, and these kids are being managed by someone else in addition to you. How do you find diabetes? What are you looking for? Ketones and glucose. There it is. I knew it was out there somewhere. So you start spilling glucose when you have so much sugar in your urine that your kidney can no longer reabsorb all of it. So there's a threshold, and it's about 200. Above that, you will begin to see glucose in the urine. Urine ketones are a quick, dirty way to look and see if the body is making ketones. Why does the body make ketones? For diabetes? You don't have insulin, so you can't use the glucose you have. What 2 organs are very picky and absolutely must have glucose? So in the absence of it, we'll want ketones instead. Brain and heart. Very good. All right. Here's Henry's urine. What do you think? He's got some issues. He has diabetes. So he's got 2+ ketones. That's more than a little. He's got 3+ glucose, and he's got concentrated urine, so he's somewhat dehydrated. Good. A bunch of bears. A lounge, a sleuth, a parliament, or a deceit. I do like the thought of a lounge of bears. All right, it's a sleuth of bears. I don't know what they're up to either. All right. Any questions about urine stuff? Cool. Now Henry's pale. So he's 20 months old, he's African American. Aunt showed up and said, he looks sort of ill. He's been eating and drinking fine. He doesn't have any sort of URI or GI symptoms. He's not been febrile. He's totally normal. Developmentally, he's on track. Theirs is vital. What do you think? Pretty tachycardic, I heard. Yeah, 150 for a theoretically well-appearing 20-month-old. Anything else? I agree. What would you look for in physical exam? Hands. How so? Palm. Okay. Lips. Good. Gums. Excellent. Eyelid. What part? The conjunctivis. Good. I like it. What's wrong with Henry? Again, I've told you nothing, so I enjoy this question.
Iron.
No one's voting for anything else. All right. So, if you had to guess what it was, what would you say? He's drinking too much milk. All right. What do you think of his CBC? Say it. You're all staring at it. His hemoglobin, yes, it's a little low, 5.1. What about his MCV? It's really low. All right. So red blood cells, as you know, are the bits that carry oxygen. They live for 120 days. We make them because of tissue oxygenation. So if you're not oxygenating enough, you make more of them. And you also need a functioning kidney to make erythropoietin to tell the bone marrow to do it. Size. So it depends on your age. Normocytic is 75 to 94. If you're terrible at remembering ranges, the quick rule to remember is 70 plus 2 times your age in years. So if Henry's 20 months or 2 years, what should his MCV be above? 74, yes. So the reason I like to remember this is because typically everyone's lab is different, and it may be giving you an MCV range for an adult, which is going to be very different than children. So large blood cells are above 94. That comes with folate or vitamin B12, other rare things. And then small can be iron deficiency anemia, lead poisoning, and thalassemia. We look for reticulocytes in certain patient populations all the time, like kids with sickle cell disease or those who are coming anemic. This is how you tell what the bone marrow is doing in response to making red blood cells. If you see reticulocytes, it's because the body's message is, I don't care how old it is, I need you out there picking up oxygen. So there's going to be more immature red blood cells. So acute anemias as well as chronic hemolytic anemias, you'll see this. If your bone marrow doesn't work anymore, or you don't have the bits and pieces to actually make a red blood cell, your reticulocytes will be low. The hemoglobin itself is what physically picks up the oxygen. It should be 11.5 to 14.5. I can't tell you the last time I actually saw a kid with a normal hemoglobin that wasn't dehydrated, and that's cheating. So it also varies by age and gender. We know that there's different types based on age. You should have fetal hemoglobin that transitions over to adult. If it's increased, it's a response to things like congenital heart disease, again, not having enough oxygen, being at high altitudes where there's not as much oxygen. There are certain disease states like polycythemia vera, and then being dehydrated. You're anemic because of one of 3 things. You're not making it, it's being destroyed, or you're losing all of your blood in a hemorrhage. So you don't make it if you can't. So aplastic anemia, you don't have the erythropoietin from your kidneys to tell you to make it. Or again, you don't have the iron to physically do it, or bone marrow doesn't work. Destruction comes with sickle cell disease and hereditary spherocytosis. These get sucked up by the spleen and destroyed, or you bleed. Or also fluid overload. So everybody that comes to my ICU gets a boatload of fluid, and then the next day I can guarantee their hemoglobin is 2 less than what they were when they came in. So what wins in kids? Healthy kids. Iron deficiency every time. So it's diet, and we're terrible at this. So toddlers love milk. Love it. I once saw twin little 3-year-old girls as a resident that her mom said, yes, they drink a gallon of milk a day. Between the two of them. Would you care to guess what their hemoglobins were? They were 4. And I think one was 3.5 and the other one was 4. So they were twins. They were doing everything together. Part of the problem is there's a very important transition that should happen from bottles to when they're infants into now you get to sit at the table and you get to drink milk. And milk becomes a beverage with a meal, not their primary food source. But kids are used to having a bottle is what they get all their fluid from. The darker the green vegetable, the better it is in terms of containing iron. Also things like meat, eggs. It's important to ask families, do you intend to be vegetarian, to figure out if they're going to miss a primary source like eating meat. Blood loss is very common. This is particularly true of adolescent girls who don't have the greatest diet in the first place, and then they start having periods, or other occult things which are much less likely in children than they are in adults. Or you can't absorb it. So celiac disease, small intestinal lopathy, and these things are rare, at least in children. And pregnancy, I hope, is fairly rare in adolescents. So finding it. So iron studies often include looking for ferritin. This is the protein that physically stores iron. If you haven't got it, you don't have the protein that's storing it. Transferrin transports the iron. If the body is short on iron, it's going to make more transferrin because it's going to desperately try to pick up as much iron as it can through the GI system. Your total iron binding capacity goes up, again, because you're trying to maximize the amount of iron that gets grabbed and utilized. And then, obviously, your total iron is low. So here's a little chart, if you like charts and you like arrows, for your own reference, because not so much in the clinic where you are going to catch this and you're going to know the kid and you're going to have a growth chart and you're going to know what their dietary intake is. But if you catch this, if you're working in more of an urgent care setting, looking for these things becomes a little more tricky if you're trying to figure out whether there is some chronic disease going on or you've missed a hemoglobinopathy. So this is a green jay. It's in the family of blue jays. Everybody know what a blue jay is? Yeah, so if you put a bunch of them in a tree, defeat, disgrace, family, or party. And I can tell you that green jays are about 3 times as obnoxious as blue jays. You can only find them in extremely South Texas. The blue jays are particularly loud just now. They seem to know it's spring. I like it. They're a family. They're a dysfunctional one that yells at each other all the time. I like it. Ooh, Grace is catching up. All right. Yes, it is a party of jays. All right, Henry's gaining weight. So he's 14. Mom's bringing him in because he's gaining weight. He's gained 20 pounds in the last 6 months. She wants to make sure there isn't anything wrong with him because she thinks that there's a thyroid problem that runs in the family. Maybe the aunt has it. So, but otherwise he's doing fine in school, no change in bowel or bladder habits, no change in his energy, except he likes to stay up a little bit later. And he doesn't like to get up for school anymore. He was active in sports before he started high school. There's his growth chart. What do you see? So what about his stature? It's the same. So he's hanging out between the 25th and the 50th percentile and has since he was 8-ish. What about his weight? Woo. Going up a bit. Here's his vital signs. Anything? Nope. Good news, he's not hypertensive. What would you look for in physical exam for Henry? Large thyroid, okay. Hair dry, skin dry, striae, I think someone said. Okay. Anything else? Acanthosis, good. Looking for what? Good. Which one? Yeah, type 2 or insulin resistance, good. What is your differential for old Henry here? Yeah, lack of exercise because he doesn't play sports anymore. But yep, increased caloric intake, type 2 diabetes, thyroid issues. Gets weirder from there. So what are you going to do for him? Well, I liked when it was dead tie. It's like the test question you can't stand where it gives you like multiple combinations of letters. All right. So if you wanted him to be hypothyroid and it was clear, what would you do? So you'd give him a thyroid mass. What else would you do? Did you change any of his history at all? Okay. So give him a change in activity, as in he's much less active. Okay. Anything else? Fair enough. Constipation, good. So it's easy to order these tests. It's easy to want to blame weight gain on thyroid. It's unusual that that's really what is going on, absent a strong family history or something that you see on a physical exam. So if there's an enlarged thyroid, that's a slam dunk. Send your test. Beyond that, you need to have more than one sign or symptom. Being, again, that there's a goiter, that there's new fatigue, not this has been going on for years, cold intolerance, growth failure, so you don't see the kid who's following the line with his stature but not his weight. Constipation, dry skin, or if they're little, following up an abnormal newborn screen. The opposite, if you're worried about hyperthyroidism, the rule is still the same. So you need to have more than one symptom. So they're hyperactive, they're impulsive, and they are tachycardic or they're losing weight, heat intolerant, school performance. So the flip side of blaming the thyroid for weight gain is trying to blame the thyroid for the kid who just won't sit still in class. It's very unlikely to be helpful just for isolated obesity, unless it's new and, again, the linear growth is also involved. Even severe hypothyroidism doesn't cause that much weight gain, and it's mostly water, not fat. Being mildly short stature but growing at a normal rate, failing to thrive, it's almost always picked up on newborn screens now. And again, it doesn't affect weight gain more than growth. Hair loss, no. Family history without the symptoms is not a valid reason to send it. And then just hyperactivity without a goiter. Less is more. The more you order, the more likely you are to find something that's just slightly off and lead you down the rabbit hole. So if you had to pick just two, which would you send? Yep, TSH and free T4, good. TSH is the essential one. This is what's telling you what's the response of the endocrine system to the amount of thyroid that's actually there. So if it is normal, you are neither hypo nor hyperthyroid. But of course, you never get like a stone cold normal range. You get something gray and fuzzy in the middle. So the free T4 you send because it's the biologically active fraction, and there's lots of things that change thyroid binding protein and will mess up a regular T4. This is unlikely to change. So you can see it being low in children who are born deficient of thyroid binding globulin, but again have normal free T4, or those who are euthyroid. And then teenage girls on oral contraceptives. Group of bats. So we're going to skip that one. It's a cloud, and that's why. So what, because I'm running out of time, you have in front of you is some kind of lab findings and then what the interpretation is. Instead, in the little time I've got, and plus this fun chart, which looks like it was drawn by like an 8-year-old, as to, and it's a really angry thyroid, which I enjoy. So how to interpret your levels based on whether they're high, they're low, and what's going on. All right, so somebody interpret this RFP for me. All you have as chief complaint is dehydration. Anybody at all? Come on. The BUN is high. So is the creatinine. Yes? Sodium's a little high. Glucose is high. Yes. Anything else? Yeah, the bicarb is a little low, so it's 17. How do you make heads or tails of this? What do you do with this? Do you call me and admit this kid to the ICU? He's well appearing, his vitals are fine, not drinking. Anybody? So who remembers what an anion gap is? Anybody? All right. So if you have an acidosis, because it's pretty common in dehydration to get a bicarb that's a little on the low end of the spectrum, you need to figure out if there's a gap or there's not. And so the math there is your sodium minus your chloride and your bicarb. So it's your things that are positive minus your things that are negative. And I think the answer is 21. Normal is my favorite, because why wouldn't you just pick one number? It's 11 plus or minus 2. So 9 to 13 should be a normal anion gap. If it's high, you think about a certain set of things. There's an acronym. Does anybody know it? Mud piles ring a bell? Yeah. Oh, I like the moan that came with that. Forget mud piles. It's like 90% geared toward adults. The things in kids it's likely to be are ketones, so DKA, uremia, so a high BUN, lactate or dehydration, or toxins. So kid got into the bottle that contains Windex and thought it was juice. The reason I think this is always helpful is for something like this where you've got a kid who has sort of a high-ish glucose and your thought is, oh, is this DKA and I'm missing it? Maybe. What if Henry has diarrhea? What changes? What's different? Sodium's normal this time. What happened to his chloride? It went up. So diarrhea causes a hyperchloremia. And this gap, if you do the math, I think is only 10. 20, yeah, good. So if you see a RFP and what you get is a non-gap acidosis, in kids it's almost certain to be something like diarrhea, or much less commonly an RTA, or if you're in the hospital, you've been on normal saline-containing fluids, and we've given you a boatload of chloride. So it's extremely common to see this RFP on kids who've been inpatient for a while on IV fluids. And then this is my favorite one of all. What do you call a group of otters? A nest, a romp, an implausibility, or a pack? One vote for I hope it's a romp. And there's the vote. And while you're thinking really hard, I will put a plug in that if you're going to stick a child, please use EMLA, particularly when you're in an outpatient setting and you have time to minimize the pain that's affiliated with drawing labs. You're welcome. All right, you're right. It's a romp. And how cute is that guy? All right. Questions, thoughts? Hope this was in some small way helpful. If nothing else, we have slides with a whole lot of stuff on it that you can read. All right, thanks.